Welcome, everybody. We're very, very pleased that you have joined us today. My name is Cindy Brown. I'm the founder of the group and one of the administrators. The group is growing very, very quickly, and we're pleased to have all the new people also. I'd also like to introduce Morgan Hart, who is the other admin for the group and is just so much. She brings so much knowledge to the group. She starts Monday in PA school. So she's got a lot of experience between her experience of being ill and then now working in the medical field. So we're very lucky to have her. I'd also like to introduce Lahoma Noctrab. Lahoma is the one that does the PowerPoints for us and runs the Zoom. And we're very, very happy to have her too. Lahoma is going to explain to everybody how to use Zoom and where to find the chat box, and then we'll move on from there.
Okay, hello everybody. Right now you should be seeing a shared screen, which will be our PowerPoint. And then you can see pictures of individuals over to the side. That's because we're in gallery view. I'm going to spotlight Dr. Trevino so that it will you'll just see him during the presentation. But I'm going to mute everyone else and then unmute him. So we are recording this so that it can be put on YouTube. So if you don't want your video, your picture to be on YouTube and be out in the public, then just turn your video off. At the end, we'll have question and answers, and you can unmute yourself to ask those questions, but we'll kind of direct, actually, if you have a question, put it in the chat, and then Cindy or Morgan or I will call on you to ask that question, or we can read it for you. As far as the video goes, what we ask is that you keep your camera stationary, or your device still, so that there's no visual triggers with background movement, or just turn your video off if you've got a lot of movement going on in the background. And that's why we mute too, to block out any background noises, to not interrupt the presentation. If you want to keep your video up, but you've got like a hectic background, you can go under the video settings, which is usually on the bottom, the toolbar, or on the bottom right on your app. There's a picture of a camera, and next to it there's a little drop down arrow. If you click on it, it'll say video settings or video filters, and you can go in there. You can blur your background, or you can do a virtual background. So those are some options, but if you can't figure all that out, just turn your video off. And then at the end, while you're asking questions, you can turn your video back on. Remember, if your video is on, it is being recorded and you will be seen. And if you speak also, your voice will be recorded. So that's why I said, if you'd like, you can just type the question in the chat, and Cindy, Morgan, and I will do our best to get to all those questions. Any questions we don't get to, we will get the answers and we can post those in the group. If there's anything Dr. Trevino can't answer today and needs to research, he will research that, and that will also be posted to the group. As well as this PowerPoint will also be made available to the group, and it has links in it for resources. So all of this will be made available. It usually takes about a week for us to get the video posted, because I have to post it to YouTube. I'm trying to think, is there any other questions I missed about?
I don't think so. I think you
okay.
Yeah. Covered it.
So during the Q&A, if you want to go back to gallery view, you can change your own view on who you see, but I'm going to spotlight Dr. Trevino now so that we see him. And then I'm going to mute everyone, and then Cindy and Morgan, you guys unmute and Dr. Trevino, you guys unmute yourselves to speak when it's your turn.
Okay.
Again, thank you all for being here. And thank you, Dr. Trevino, Cindy, and Morgan. So Cindy, I'll ask you to unmute. You can unmute yourself.
There we go. Okay. Morgan, you want to move forward?
Yeah, I just need Lahoma to, there we go.
There we go.
Okay, so we do want to start with a disclaimer. So by participating or listening to this content, you agree not to use this information presented here as medical advice in treating any medical condition. This forum does not constitute a physician-patient relationship. The content here is for informational and educational purposes only, and because each person is so unique, please consult your healthcare professional for any medical questions or treatment options.
And do you want to read the bio?
Okay, so a little bit about Dr. Trevino. He is a licensed and board certified doctor in internal medicine. He received his medical degree from the Autonomous University of Guadalajara in 1982. Dr. Trevino completed his residency at the Albert Einstein College of Medicine in the Bronx, New York, with an associate fellowship in integrative medicine from the University of Arizona Medical School in Tucson, Arizona.
Great, thank you. Dr. Trevino, welcome. Thank you so much for speaking with us today. I have just a couple questions so the group can get to know you a little better. How long have you been practicing medicine?
So, hi everybody, thanks for listening. I'm gonna try to make this not too boring, hopefully. I've been practicing for, I guess, 35 years almost. So
Wow. And what got you interested in treating EDS and autonomic dysfunction patients?
I think it's just the incredible need that is out there for treating EDS, autonomic dysfunction, and mast cell activation. Just incredible how many people have all these issues and are misdiagnosed and not treated, and so it just happened. People started coming and coming, and they still are.
Okay, yeah, the word's out on you. Out of the 35 years that you've been practicing medicine, how many years have you been treating EDS?
I think it's 12 now.
Okay, cool. And approximately how many EDS and autonomic dysfunction patients do you treat?
At least 1,000, more than 1,200.
It's a lot. That's a lot of patients. Okay, I think we're ready.
So I guess we're going to go through some slides. I think I'm going to try to explain what EDS is and what we need to look out for. EDS, as most of you already know, is a connective tissue disorder that's inherited both autosomal dominant and recessive ways. What it's characterized by being hypermobile most of the time, not always. You can have normal mobility and still have EDS. Your skin is hyperextendable, it stretches, and there's tissue, your tissues are fragile. You want to do the next one? And I'm not going to get into all the types of EDS. I think for our purposes today is most people are diagnosed with hypermobile spectrum disorder, or hypermobile EDS in previous terminology, which is what most people that I see have. Of course, you can have any of these types of EDS, and the only way to find out would be to get genetic tested.
Dr. Trevino, can I interrupt for a second? I did
Sure.
forget to mention, if you have questions, you can type them in the chat. And then when we get to the Q&A, babe, turn that up again. We will address that. We will ask you to unmute yourself and your video if you want to read it yourself, or we'll read them for you. Because some people, I forgot to point out that there is a chat that we can use. So use the chat if you have questions during the presentation. We'll either address them then or during the Q&A. So sorry. Okay, I'm muting myself. Back to Dr. T.
I have a question for you too, Dr. T.
Uh-huh.
So with EDS, are we all alike? Are we all different?
So we are all different, and the spectrum of EDS is everything from being stiff and normal, quote unquote, all the way up to being so hypermobile and flexible that your joints sublux all the time. And you can be anywhere in that spectrum and still have it. There's plenty of people who are hypermobile who don't have any symptoms. And then, you know, one of the worst types of EDS, a lot of times people who have that aren't hypermobile at all, especially with vascular EDS. So everybody's different. The spectrum of EDS is vast.
Thank you.
So I'm going to go into, you know, what like my process of trying to figure out what are the main issues when people come in and have EDS. A lot of times I see a lot of people with autonomic dysfunction that don't even know they have EDS. But you know, in questioning, you can see what, you know, that obviously them and there's family members as well. Usually there's family members that we can identify. So the first thing that I always ask is do you bruise easy? Do you bleed more than normal? Do you scar differently? Does Novocaine and lidocaine not work on you when you go to the dentist? Sometimes opiates also don't work on patients who have EDS. And then, of course, the most important question is, do your joints sublux or just pop out of socket? And do you have a lot of muscle cramps? Because most people who have EDS, that's what their main complaint is that their joints sublux, and that's usually quite painful. In the long term, if your joints are subluxing all the time, it can cause early onset arthritis. So people who have EDS will have a lot of arthritis in their joints at a young age. And then, you know, of course, is there any other issues like, do you have any issues with headaches or muscle pain or nerve pain, or is there any weakness? Do you have hernias, prolapses? Is there any nerve damage anywhere? So what I try to do is I try to you know, go from head to toe. So most people who have autonomic nervous system disorders and EDS have headaches. Unfortunately, the headaches can be multifactorial. You can have migraine headaches. You can have POTS can give you what they call the coat hanger headaches. A lot of people who have these disorders also suffer from fibromyalgia. And there's 6 trigger points in the back of the head and in the neck that you can press on to see if there's severe pain when you do that. And then that will give you a clue that is this a fibromyalgia type pain? Is the pain more musculoskeletal? Is it coming from disc disorders? Is there any nerve disorders that is causing the pain? And unfortunately, There's also a condition called Chiari, which is causes headaches every time you sit up or stand up, and is associated with a bunch of other symptoms like dizziness, lightheadedness, ringing in the ears, vertigo, sensation of being off balance, numbness and tingling in your hands and feet. So there's so just from a headache point of view, EDS can contribute in many ways, including Chiari, which is where the back of your brain is dropped and causes headaches, especially when you sit up or stand up. But also, there's some people who have spontaneous spinal fluid leaks, and that can cause the same kind of headache as well. So going from that, then another very common thing is sleep apnea. So when patients with EDS lay down, their posterior pharynx drops, and that can cause sleep apnea. So most people with autonomic nervous system don't sleep well anyways. They have their sleeping pattern is that they may or may not get to sleep, but once they get to sleep, they sleep very superficially. They don't get deep sleep. But on top of that, if they snore, if they stop breathing at night, if they have a lot of nightmares, then we may have to get a sleep study as well. Then there's issues with the heart. So I want to make sure that they've had an echocardiogram. Do they have shortness of breath, chest pain? A lot of times patients with EDS have chest pain because their ribs move. But a lot of times, especially if it's severe chest pain, we want to be aware that to make sure that they don't have aortic or valve or mitral valve issues. So we always want to get an echocardiogram on them. Intestinal issues are quite common with EDS. So nausea, bloating, reflux. There's a condition called median arcuate ligament syndrome, where there's a ligament that presses on the main artery that goes to the intestine that causes pain, nausea, and bloating every time you eat or drink anything. People have this, lose a lot of weight, for example. And then, of course, I want to make sure that they don't have hernias and prolapses, especially after having kids. And then hemorrhoids and varicose veins. So just the questionnaires, just the questions of all the symptoms are going to help me try to figure out, even if they're not very hypermobile, if they're having trouble from having EDS. And so there's all these symptoms are on these slides. There's more that we can look into. One thing that's very important is to figure out if there's a family member who's had vascular type EDS. So is there anybody in your family who's had a spontaneous intestinal rupture, or who's died of an aneurysm in their 40s or 50s? If this is the case, then we want to make sure that you get genetic testing. So that's just the questionnaires about asking if EDS is causing you to have any problems. And then on top of that, we have to ask questions, do you have autonomic nervous system dysfunction? Because EDS, or being hypermobile, is the underlying genetic condition that predisposes you to having autonomic dysfunction as well. So then we have to go into those questionnaires, and then also into mast cell activation disorder as well, which is pretty common with people who have this issue. Also, it's pretty common to have autoimmune disorders with EDS. So I'll usually ask some questions about that as well. So that's pretty much the way I approach the symptoms, signs and symptoms of EDS. And that's where you get most of your information to try to decide if you need to move forward with the different types of testing and treatment. Do you want to? So we don't really know what causes it, EDS. There's, of course, a bunch of genetic markers that we can test for. The genetic testing is pretty inexpensive nowadays. You can do a genetic test from Invicta for like $250, and you can test for all the genetic markers. But most people that I see end up having what's called HEDS, or hypermobile spectrum disorder, and then the genetic testing will be normal. So here's just a little bit of stats for you. You know, how common is it? The hypermobile variant, of course, is the most common type. These disorders are 5 times more frequent in females than males. You can go to the next one. So EDS is inherited autosomal dominant and recessive. So autosomal dominant means that that if you have it, you have a 50% chance of passing it on to your children. Usually you can find either a mother or a father who has it. Autosomal recessive usually means that each parent gave you an abnormal gene, and so the parents may be completely normal, may have no symptoms whatsoever, but have the gene, and then because you get both genes, then you end up having different type of EDS. So hypermobile spectrum disorder is what we deal with on a day-to-day basis. It's the most common thing that people have. There's no genetic marker for this. We also see some people who have Marfan Syndrome as well at times. And basically, it's the same kind of questionnaire that you have to ask, except for Marfan's, they have different physical findings that I'm not going to get into today. We can do the next one. So a lot of these symptoms that you see on here are because of the EDS. A lot of them are because of the autonomic dysfunction, and a lot of them could be also because of mast cell activation syndrome. So the nausea, vomiting, reflux, bloating, pain, issues with absorption, all can be either autonomic issues with gastroparesis, gastric dysmotility. It can be because of the EDS, because of mast cell activation. The temperature dysregulation is usually a function of the autonomic nervous system. Anxiety and depression are pretty common. A lot of people have too much adrenaline from autonomic dysfunction, and they get misdiagnosed with anxiety because they feel shaky and jittery. So sometimes we have to figure out, is this really anxiety, or do they have hyperadrenergic POTS that is causing them to feel anxious, but it's really not anxiety. So sometimes it can get a little bit tricky in trying to figure out what's what, but usually with a good history, we can figure it out. Next one. It's pretty, the main issue with diagnosing EDS or hypermobile spectrum disorder is the history. So a lot of people will do the Beighton scoring. I don't know if that's in the next slide.
Yes, I believe it is.
So a lot of people will do the Beighton scoring, and then if the Beighton scores are not above 4 or 5, then they say, oh, that you don't have EDS. And the reality is our Beighton score changes as we get older because we do get stiffer. And the Beighton score by itself does not rule out EDS either. So you can have EDS be completely stiff and still have, you know, one of the worst kinds of EDS, which is the vascular type of EDS, where you get a spontaneous rupture of your intestines or an aneurysm that ruptures, and you didn't have a clue until that happened. So, so the Beighton score is very important because if you are hypermobile, it does render that clue that maybe things are a little, your joints are hypermobile. And the Beighton score is very easy to do. These pictures show you how easy it is to do. A lot of people who are hypermobile don't have any issues too. So there's a lot of people who are hypermobile who don't have EDS or don't have any symptoms of having EDS or having any other symptoms. They're just very good gymnasts or very good dancers. And but this is the first clue that you can pretty much in 5 minutes, you can figure out, are you hypermobile? Next one. So people with EDS have a normal life expectancy, and because everybody's different and there's so many other things associated with having EDS, you just have to say there's on a one-to-one basis where you're at, see how bad you're at, see what other disorders you have on top of the EDS, and then take it from there. But there's no, unless you have vascular EDS or kyphoscoliotic EDS, where your spine is very deformed and it interrupts with your breathing. Most people who are hypermobile or have hypermobile EDS live normal lifespans. So what are the things that we can do to try to help with this? So most people who have this disorder, the main thing that they complain about is that their joint sublux, they have a lot of muscle spasm and pain. And the first thing we have to figure out is the pain coming from muscles, joints, or nerves, or is the muscle, or is the pain from also fibromyalgia, because fibromyalgia is pretty common with these disorders. So once we figure out where the pain is coming from, there's a lot of things that you can do, but the main kind of treatment for being hypermobile is physical therapy. And we say that people who have who are hypermobile need to do at least 30 minutes of physical therapy every day for the rest of their lives. And the reason why is because the minute you stop, your muscles get weak, they atrophy, and then all the things that are associated with the subluxations and will just get worse as time goes on. So physical therapy is very important for people who have POTS and EDS. They have to make sure that their physical therapy is done either sitting or laying down, because if you try to do it upright, you're not going to last very long, and it's going to be you're not going to be successful at getting all your joints in a better place. There's several protocols that we recommend. The Muldowney Protocol is one. Muldowney has a book. It's Kevin Muldowney. He has a website and a lot of YouTube videos that you can look at. Basically, you need to be working on the joints that sublux the most, or that hurt the most, or that spasm the most. There's another lady who's Jamie Devon, who has a website for patients with EDS. And then, of course, there's a lady who I think lives in Naples or Sarasota, who's a physical therapist who has EDS and POTS. And she has a website called exercisewithpots.com. And I think she's still doing that. So those are the three protocols that we recommend. I think the main thing is to realize that if you want your joints to stay healthy, you need to spend some time every day making sure that they're strong. You can go to the next one. Other things that you can do, of course, in the morning, a lot of people wake up with a lot of stiffness. They seems to, if you get in a warm bath with Epsom salts, that seems to help people get going in the morning. In general, you want to try to avoid any orthopedic surgeries. People who have EDS, they don't do well with surgeries. They, of course, they bleed more. They don't heal right. Sometimes you have to put double stitching on them. You have to leave the stitches on for at least twice the normal amounts of, the normal amount would be 10 days. Sometimes you have to leave it for 20 days. And you just got to expect this. You can bleed more during surgery. In general, you just, if you can avoid surgery, then avoid surgery. There's some compression garments that you can use. Lahoma, do you want to comment a little bit on the compression garments?
Yes, I actually just happened to find these compression garments, and I found them very helpful. But then when I started physical therapy with a physical therapist, her name there is Marcia Pareto. She does offer telehealth visits. She was recommended by my geneticist, and she is listed as one of the providers on the EDS website. She actually recommended these, and I'm like, great, I'm already wearing them. There's two specific, they have like 3 different types of ankle to belly leggings, tights. And she recommends these 2 brands specifically, the, I don't know how, I won't say them right, Stabilix and Endurance. The reason she recommends both of those is because the Endurance is a little cheaper. They're $110. The Stabilix are like $170. But if you can buy them on Amazon or through their website, they often have sales of the old styles and colors. So that's when I buy them, and you can get them cheaper. I find the Stabilix are very supportive. If you have autonomic dysfunction with your EDS, they offer the compression. So they help with the bloating, they help with the blood pooling, but they also offer the proprioception and joint support. So they basically have like reinforcements that wrap around your calves, wrap around your knees, wrap around your thighs and your hips. So they work like that, the tape that the chiropractor or physiologist or the physical therapist might apply to you to support your joints. And you get that with the leggings. And so I wear them every day. I put on my compression socks and then my compression leggings, and I wear them every day. When I find I don't, like if I'm not feeling good or I'm just slow or don't do my morning routine, I notice right away I get bloating. So it even helps with the GI issues. It helps, and they're not overly tight. They're not like, the I'm 48, but the old pantyhose that cut into your belly, or, they're very graduated, they're expensive, so they're well made. So I really highly recommend this brand. And the link is there, and these are all the links in this PowerPoint are clickable. So when we post it, you'll have all these resources. So I think that's enough information about them. But if anybody has any questions, you can reach out to me about them. But they do also offer sleeves and shorts, because I live in Florida, so it is hot. I tend to freeze all the time. So that's the least I wear, is the socks and the leggings, and then I layer up on top of it. Like if I'm going out, I find jumpers or dresses or pants that look cute with them. But leggings are popular these days, so it's easy to wear them as just clothing. So back to you, Dr. T.
You can go ahead and get to the next slide. There's a bunch of things that most patients with the EDS can do on a day-to-day basis to help them out, to help you avoid injury, to help you prepare for a surgery if you're going to have surgery. And there's a bunch of including the Facebook, and here's some other places that you can click on to try to, and then Lahoma is also going to print a list of things that everybody can do on a day-to-day basis to help them out with the different issues that happen with EDS. Here's the alert bracelet that people look at and just throw away. It's good to have. I think everyone who has EDS should have one of these on them, and share it with whoever you whoever your medical provider at the time is. This is just my information and the EDS information. And I think we'll go into questions now. I think there's a bunch of.
Yes, we have a lot of questions. Okay, I'll start. Dr. Trevino, is there a genetic testing for hypermobile EDS?
So I think that's coming. I think they are finding some different genes that are associated with HEDS. It has not been, it's not, there's nothing right now, but I think soon we'll have something. Just keep your eyes open in the next year. I think we'll have something.
That's encouraging. Okay, great. Can you have more than one type of Ehlers Danlos?
It would be very rare. I think most people have just one type based on whatever gene you got inherited.
Okay. And what is C-spine instability, and how do you diagnose and treat it?
So that's like a whole topic for another podcast. Basically, what happens when you have any vertebral instability. So what happens when you have EDS, your discs can rupture spontaneously. You can have hypermobile joints inside your vertebrae, can be very hypermobile, and it can pinch nerves. It can cause compression of your spinal canal, and it can cause a multiplicity of symptoms, everything from headaches to neck pain to nerve damage in the different nerve roots, numbness, tingling, weakness. If you move your neck into one position or the other, and you get symptoms that show that there's a nerve being pressed every time you move in a certain position, that gives you a clue that there may be something going on with your cervical spine, and it may be unstable. Usually we get flexion extension x-rays to start with. If we suspect that there's a nerve impingement, then we also will get MRIs to try to figure out where it's being impinged. And usually you'll end up having to go to a neurosurgeon to get that treated. A lot of people have to have fusions to treat it. Physical therapy would, of course, be the first line of treatment. A lot of the symptoms that you get with cervical instability, you also get with autonomic dysfunction. And so sometimes it's hard to figure out, do you really have this or not? I get asked all the time, do you need the MRIs that are flexion extension? And I was told by a neurosurgeon that a regular MRI should be able to help you see if there's any nerve impingement, and that with a clinical picture is what you would usually be enough to try to figure out if you have anything that needs further treatment.
Okay, great. Dr. Trevino, can you discuss the overlap with autoimmune disease and dysautonomia?
So what we find is that 50%, about 50% of people have other autoimmune conditions that are associated with EDS and dysautonomia. So a very common one is Sjogren's, where you have dry eye, dry mouth. But you can have rheumatoid arthritis, Hashimoto's, colitis, and all the other autoimmune disorders are pretty common with these two disorders. We actually think that autonomic dysfunction is an autoimmune condition, and also we're in the process of trying to prove that.
Great. Can you discuss vascular variables and vascular manifestations of EDS, particularly venous blockage and compressions?
So there's mainly three types of compression variables, vascular compression variables when you have the EDS. Of course, the one that everybody knows about is median arcuate ligament syndrome, and that's where the median arcuate ligament presses on the celiac artery and celiac plexus and causes pain, nausea, and bloating every time you eat or drink anything. People who have this disorder usually lose a lot of weight. That one is diagnosed with an ultrasound of your celiac artery. And then we have Nutcracker Syndrome, which is usually more seen in the pediatric realm. Nutcracker Syndrome is where you get the renal vein is being compressed, and that causes hematuria. It causes you to have blood in your urine. But it also can make you high if you have a kid who has high blood pressure and you can't. Why does this 15 or 18-year-old kid have high blood pressure? Then you also have to think of Nutcracker Syndrome. So the treatment for Nutcracker Syndrome is not easy. A lot of times you have to auto transplant the kidney to get rid of the renal vein occlusion. You have to get a venogram of the renal vein, usually through a CT scan to make the diagnosis. It's a hard diagnosis to make. It causes pain and pelvic congestion a lot of times as well. I haven't seen many cases, but it's associated with these disorders more commonly. And then May-Thurner is where there's a blockage of the iliac veins, mostly on the left side, and it causes also pelvic congestion and swelling in your left leg. It can do both, but mostly it happens on the left, and this can produce the slow venous return because of the obstruction can cause venous thrombosis. So, I mean, that's just like an overview of those things. They're pretty rare. I haven't seen any in 12 years I've been practicing, but I know it's out there. And if you have it, treatment is not, of any of these compression syndromes, is not easy.
Thank you, Dr. Trevino. What are some ways we as patients can communicate with different specialists, hospitalists, and primary care doctors that don't have any experience with EDS? How do we educate them?
So Lahoma is going to provide a whole kind of 3-page, I think it's 2 or 3 page things that people can do when they have rare disorders. Basically, you have to be as informed as you can. This is the paper that was printed, or that's on the stiffperson.org from the Stiff Person Foundation. You know, go through that. I think a lot of the things that you would think would be common sense when you're dealing with the medical on a day-to-day basis, with medical people on a day-to-day basis, a lot of times it's not easy.
Okay.
So the more prepared you are, the better.
As you know, going to the ER is a pretty traumatic event for most of us, because the ER department, ED departments just don't seem to understand about EDS. So how can we advocate for ourselves when we're in the ER and trying to get them to understand?
Well, of course, again, it's the same thing. I think reading this paper will help you
Okay.
no matter where you're at. In the ER, it's difficult because it's usually busy. People, the ER wants to get people moving. They want you to be evaluated and make a decision whether you need to be admitted or you need to go home pretty quickly. So depending on what is your problem, you can ask to be tested for it. So a lot of times, for example, patients with POTS will go to the ER because they've passed out. Their blood pressure and pulse are checked in a laying down position, and then they're normal. And then the doctor comes in, well, everything's normal. Your blood pressure is normal. Your pulse is normal. You look fine now, go home. And then, of course, as soon as you stand up, you pass out again. So ask them to take your blood pressure and pulse in a standing position at 1 and 3 minutes. If your pulse does go up and you start to feel dizzy, maybe they'll figure it out that there is something going on that needs further evaluation. But basically, you just have to continue to advocate for yourself, continue to ask for people who may know more about your disorders, and do the best you can. It's not easy.
Thank you. That was very good information. Once somebody is diagnosed with EDS, there's a slew of comorbidities that are brought up to look into. And that's pretty much when the jigsaw puzzle comes together for some. But how do we navigate that? Everyone wants to get checked for Chiari, gastroparesis, cranial cervical instability, and POTS. Since we've suffered so long, is there a path for us to follow with that jigsaw puzzle?
You know, the path that I usually use is, what is your most disabling symptom or symptoms or conditions or problems, and then address those first, because if you can get the most disabling things better. So if your most disabling thing is pain, then you have to address that. If it's fatigue, that's crushing and you can't get out of bed, you have to address that. If it's brain fog and you can't work, you have to address that. Those are the 3 more common things that happen both with EDS and POTS and mast cell. And sometimes you have to treat all 3. If you have sleep apnea and you're fatigued all day, that has to be addressed as well. So I think what I try to do is I try to go with the most disabling 2 or 3 things, and then see if I can work those up. See if I can figure out what is causing your fatigue. Is it all 3 or 4 things that are causing your fatigue, or 5? Do you have an autoimmune condition that's contributing to this as well, or fibromyalgia? And then try to address each and every one of them to try to make you feel better. The problem with this disorder is that you could have fibromyalgia, EDS, dysautonomia, and mast cell, and all those things can cause you to feel severe fatigue. And you have to treat all of them differently. And because the treatment for mast cell is antihistaminics and allergy medicines. The treatment for fibromyalgia is medications for nerve pain. The treatment for POTS is also very different. And usually if you can address all of the things that you find, then your fatigue will get better. And then you move on to the next thing. What's your next most disabling symptom? What is it caused by? And you just go one by one. And sometimes there's so many issues that it takes a while to figure it out.
Thank you. Dr. Trevino, many of us are on Medicaid or Medicare or both. Do you have any suggestions on how we can navigate the government types of insurances to get tests approved? You know, we get denied a lot. And are there any suggestions on how we as patients can help to keep that from happening?
Well, just keep fighting. Don't give up. Is my best suggestion. If something gets denied, reapply, resubmit, ask for another opinion. Do the best you can to keep plugging, because most patients who have these disorders usually know what they have, and they know that even though the insurance denied it, that it doesn't mean that they don't have it. It's just that the insurance denied it. And so sometimes you have to get a consult, you have to see a neurologist, you have to see another specialist, but just keep plugging at it. And I think the people who do the best are the ones who are persistent at not giving up, especially when they know they have a condition that is just not being recognized.
Okay, we only have 2 more questions, and then we're going to be opening it up to, open questions. So while we're doing the last 2 questions, if you have a question that you'd like to ask Dr. Trevino, could you please just put in your chat that you have a question, and then that way Lahoma and I will know who to call on next. So, we're open for questions. So, okay, the Mastocytosis Society has an ER protocol that is signed by a doctor for mast cell, which can be really helpful, but sometimes it's ignored. Any suggestions on when we do have that? And I know we're talking about mast cell, but when we have that form filled out and they're ignoring us, any suggestions there?
Well, I would just, if they ignore it, I would just make sure that you tell the nurse or whoever is in charge of your chart to please attach it to your chart. If you have EDS and you're going to have surgery, make sure that you get evaluated before surgery. Make sure that the doctor knows that you may bleed more than normal, scar differently. It may take you longer to heal, that you're going to heal differently. You may scar differently, and that during the surgery, they may have problems with bleeding. They can use desmopressin if they need to, which is a drug that has been used for patients who bleed too much, either post-operatively after they have a baby, or post-operatively, and So just have a plan before, have a plan during, and have a plan after, and just try to advocate to yourself, to the nurses, to the doctors, that this is what needs to happen beforehand. This is the things that can happen to me. Novocaine, lidocaine may not work. Opiates may make me feel terrible and may not work on me either. after surgery. So it may take me, I may have a lot of pain for a lot longer than normal after I recover from whatever procedure you're having, and just let them know that that's the case with EDS, and that's what we expect. And hopefully at some point along the way, somebody will listen to you.
Okay, thank you. Our next question we've kind of gone through many times. We are newly diagnosed, learning along with our care team, but we know enough to be scared and try to advocate, but sometimes it can be challenging when we as patients don't have the medical terminology. How can we work with shift nurses in inpatient scenarios to explain EDS? Kind of similar to what we already talked about, but I don't know if you have any additional things you'd like to add.
I mean, I think the same. It's just the same answer is you continue to advocate for yourself, and you know more about yourself than anybody else, and you got to pass on that message to whoever will listen. And a lot of times it will fall upon deaf ears, but you got to keep advocating for yourself either way, and then whatever happens, but at least you did the best you could.
Now, Cindy, I'm sorry to interrupt. I've been trying to put a question in the thing, but it's not sending it anywhere. It's just sitting there.
That's okay. I'm going to ask one more question and then you'll be first. How's that?
Oh, okay. Thank you.
That sound good? You're welcome.
Yeah.
Last question that we're going to provide, and then we'll open it up to Dr. Trevino, is my electrophysicist didn't know how to treat EDS and remove my surgical staples too soon. He restapled me and waited a long time to remove. He called Mayo Clinic for guidance, but was unsuccessful. Is anyone working on such guidance for doctors, like in this scenario where they can go to I don't know if you have a medical terminology website that you guys use, but what would you recommend in that scenario?
So the problem with going to a specialist is that they'll know a lot about whatever it is that they specialize in. And so you go to an electrophysiologist, he'll know about all the pacemakers and how they work and what, who needs what and how to diagnose it and all that. But when it comes to putting stitches in for somebody who has EDS, they're just not going to have a clue. So, there again, I mean, it's the more that you, depending on how many disorders you have together, you have to make sure that they're addressed. And so if you're going to have a procedure that's going to need, for example, anesthesia, you may want to tell them, hey, Novocaine may not work for me, and I may need to have IV fluids, especially if you have autonomic dysfunction in POTS during the surgery, and I may bleed more than normal. And so it's the same issue over and over again. You're the one who has to advocate for yourself and realize that just because he's a cardiologist doesn't mean that he's going to know everything about your disorders. And so, again, having a plan, if you have mast cell activation, this is what I need to do before my surgery. And I need to take my antihistaminics and my Pepcid and my Cromolyn. And then I need to make sure that I have Benadryl on standby, and an EpiPen sometimes it is needed, and steroids are needed sometimes. So I just need to be prepared to address all the issues that you may have during whatever procedure you have, before, during, and after the procedures. And so I think just making a plan, having your primary doctor, or I can help you as best I can deal with all these situations.
And that's a good opening to say that Dr. Trevino is accepting new patients. So if you are looking for a doctor and you've not had success, his contact information is in the screen, or I can post it even in the group, but he is taking new patients.
So
Right, Dr.
what's the first question?
Okay, so go ahead, Kelly.
Dr. Trevino, I want to thank you for your time, first of all. Second of all, I have 5 vascular compressions. I've May Thurner's, pelvic congestion syndrome, Nutcracker, MALS, and I have a compression in my jugular, along with gastroparesis, and the motility doctor I'm seeing keeps telling me my pancreas is thinning, but all the test results I get back say that I have pancreatic insufficiency and a fatty pancreas. Are all of those related in some way? Could Ehlers Danlos, could that contribute to any of, I mean, I just have so much stuff going on. I don't know where to, if a doctor asks me if I'm nauseous, well, yeah, I'm going to tell him, yeah, because I have all these GI problems. And, even without the GI problems, the kidney and the pancreas can cause nausea. So I'm not for sure exactly. Do you think that getting genetic testing would be something that would benefit me?
Sure. I mean, I think that with all those vascular issues, you definitely should get genetic tested.
Okay.
That's very easy to do. It's just a swab and it's
Mhm.
pretty inexpensive. So I would definitely do that. That could help you with some of it. The problem that you have is that a lot of the disorders cause a lot of the symptoms, and
Yes.
you have 3 or 4 disorders that cause the same symptoms. So, especially for example, with median arcuate ligament, if you have that, that's going to cause problems. But if you have gastroparesis on top of that, or gastric dysmotility, that can cause the same kind of symptoms. Mast cell can cause the same kind of symptoms. So it's hard. You have to sort of do one by one, make sure that all of the things that you have are treated as best as possible, and then reevaluate how do I feel with this.
Okay. Is there like a geneticist doctor that I go to see for this, or is this?
I think your primary can order that Invicta test for the genetic testing. I think it tests for 200 different types of things.
Okay.
There's one that tests for I think 14 or 17, and then the other one is a lot more extensive. But yeah, I would do the extensive one.
Okay. So, okay. I'm in the process of going from a regular GP over to an internist, in the hopes that the internist has.
Get out of my room, one.
What?
Go ahead, Kelly.
In hopes that the internist has a little bit more knowledge of all the different problems that I'm having.
Like, unless they've been exposed to them, it's going to be hit or miss, I think.
Yeah, well, my motility doctor is the one who recommended the internist. And one of the reasons that I'm doing this is because, and don't get me wrong, I love my general physician. I think he is a wonderful GP, but he has major serious issues. If I have a doctor that's out of state and they want certain blood work or certain tests run, it's like I have to move mountains to get him to do anything. Even when I sit down and explain things to him, he still won't do it. And even having doctors that live in the city asking him to order things, he just won't do it. So I have that issue with him as well. And I need somebody who's going to be in my right corner, who's going to help me get through all this and figure it all out.
Yeah, that may also be insurance-based. So a lot of insurances don't allow anybody but your primary to order the test. So sometimes, you know, you'll go to a doctor and they'll say, oh, I think you need this and this and that test. And then you go to your primary and he goes, no, I'm not going to order it.
And that's not what's going on. So
And it's not his fault, it's insurance-based.
yeah, and you know, I don't know what to do about it. I understand the position it puts him in, but you know, when you have as much stuff going on as I do, you know, I need somebody who's gonna stand behind me and help. And I just don't think, and he's a very intelligent man. I just don't think he has any idea with all the compressions and the pancreas and, you know, all that. I just don't think he has a clue exactly, you know, how in depth some of this stuff gets.
It's not an easy, those are all very difficult diagnoses. They're difficult to diagnose and difficult to treat. And
Yeah.
not always, treatment is not always successful.
Okay, the one last question I have to ask is, since I have pancreas insufficient, I had ulcerative colitis and I had my large intestine removed. So I have an internal J pouch. And then I have the gastroparesis, the bowels, the pancreas. I'm you know, dehydrated most of the times. But I don't think I'm getting any nutrition either. Is there a way to find out how deprived I am of nutrition? You know, the thing I dislike the most is if I go into a doctor and I say something to them about feeling like I'm malnourished, I'm overweight. I know I'm overweight. You don't have to tell me that. But they'll
You're
look
still
at,
being malnourished and be overweight.
yeah, that's exactly, they'll be like, you're overweight, you can't possibly be malnourished. I'm like, you know, I don't care if you weigh 100 pounds or 600 pounds, but if you're shoving nothing but McDonald's and soda down your throat, you're going to get malnourished.
Well,
You know?
there is blood tests you can order to see where your vitamins are, as well as, you know, where your protein levels are, and
Okay.
and there is ways of diagnosing malnourishment.
Okay.
So it's just blood tests that you really need to make that diagnosis, and then you know, do a journal of how much actual food you're intaking every day, and if you're not intaking enough calories, sooner or later you're going to be malnourished, and I
Right.
think that's you know, you just have to find somebody who will listen.
Yeah. I'm pretty sure I'm malnourished, and I've been begging for at-home IVs because I just can't tolerate being in the emergency room or a short stay unit for 3 and 4 hours at a time, getting fluid.
IVs are tricky, you know, if you need them, you need them, but
Right.
they're a non-sustainable therapy, and you want to try everything possible first before you go to IVs.
Okay. All right. Thank you so much for your time.
Thanks, Kelly. I'm going to, I want to give you guys that are asking questions a chance to ask Dr. Trevino directly. If you're not comfortable doing that, just tell me and I would be more than happy to, you know, read the question for you. The next question is about spontaneous brain herniations. Anybody, you want to talk about that? You want to ask him or you want me to ask it? Are they all?
I can read it. I mean, what about
There you go.
spontaneous brain herniations, meninges tears, similar thinking with different tissue? If you have EDS, my guess would be yes, it's similar thinking with different tissue. It's your tissues are fragile, and you can have spontaneous disc herniations. You can have spontaneous tears, spontaneous spinal fluid leaks. So yes, I would say it would be the same. I've never seen a spontaneous meninges tear, but I think you would get an MRI with and without contrast and see where it is and what it's doing, and then see some neurosurgeon to try to figure out, is it something we just watch, or is it something we have to do something about?
Thank you, Dr. T.
What are the recommended treatments for severe joint, muscle, chest, and body pain? So it depends on where the pain is coming from. So if the pain is coming from the joints and muscles, it's one thing. If the pain is coming from nerves, if the pain is coming from fibromyalgia, which is considered a neuropathic pain as well, and or is the pain from somewhere else? And so usually it takes a little bit of figuring out where is the pain is coming from, or is the pain coming from all the areas? Is it coming from the joints? Is it coming from the muscles and the tendons? And it's neuropathic pain, and there's nerve involvement. Then you have to treat all the different types of pain with muscle relaxants, pain medications. If you have all body pain, that usually means you have fibromyalgia, so you have to treat that with either gabapentin or Neurontin. You can try using things like low-dose naltrexone that helps some people. So there's a lot of reasons to have pain. If you want to get out of pain, and you may not be completely successful, but at least get the pain level down to more tolerable. You have to figure out where the pain is coming from, and then try different things to deal with all the areas where the pain may be coming from. When people have mast cell activation, do they also have eosinophilia? Eosinophilia is common in people who have multiple diseases like parasites and eosinophilic esophagitis, etc. I don't think the mast cells and the eosinophils are completely related, although I do see a correlation with people who have eosinophilic issues and these disorders. But whether they're completely related, I don't think so. High rates of being transgender people and or autistic people have EDS, and higher rates of being transgender and or ASD if you have EDS. Is there a question in there?
I think they're just asking if that's
Common.
if that's coming. I could go back and see who wrote that. If the person who wrote that wants to unmute themselves and ask, that's fine. If not, you can.
I do think
add
that a
more to
lot
the
of
chat.
people who have these disorders are high rate. There is high rates of transgender and autistic people. What is ASD? What does that stand for?
That was my question. Well, my comment. It's something, I'm transgender and autistic myself, and I've noticed that a lot of transgender people have Ehlers Danlos and vice versa.
Yes, I've noticed that same thing as well. I don't know if there's a formal sort of association, but I do think it's very common.
There's starting to become some things published about both being transgender and autistic and the connection with mast cell and EDS.
Yeah. All right. People with EDS are more prone to post-viral conditions like CFS, ME, POTS. Are these conditions autoimmune? Also fibro. So yeah, I think that people with EDS are more prone to post-viral. I do think that a lot of them are autoimmune. I can't prove it, but I do think there's an autoimmune component too. And I do see a lot of people with fibromyalgia also have these same issues. I don't think fibromyalgia is an autoimmune condition, but it's more like it's a neuropathic sort of issue. But there could be autoimmune components as well. So yes, people with EDS are more prone to have all those things. Will you please discuss treatments for HEDS, POTS, MCS, ME/CSF, and that warrant the need to see a specialist? So, yeah, I mean, that's a whole podcast in itself. HEDS, I mean, I can name a few things, but certainly if you have neurologic issues like Chiari or tethered cord or cervical instability, all those things need to be seen by a specialist. Median arcuate ligament, sleep apnea needs to be diagnosed and treated a lot of times by a specialist. So yes, tons of things can be treated by specialists. POTS, the actual orthostatic tachycardia needs to be treated by somebody who understands all the medications that we use. MCAS needs to be referred to a mast cell specialist if you have alpha tryptosemia, if you think there's mastocytosis, there's genetic testing that needs to be done for Mcas as well. ME/CSF, I think that also needs to be seen. I mean, a lot of rheumatologists will treat that. That's more common and more well known. So I think there's, a normal practitioner or internist could also treat that. Is it contraindicated to get steroid shots in the joints? No, it's not. A lot of times they help. Unfortunately, lidocaine a lot of times doesn't work, but it's not contraindicated. What about chiropractic? Should patients with EDS have neck manipulation? No, they shouldn't. You can have the little tappy thing that they use. Anything that's very gentle is okay. Deep tissue stuff can cause damage, bruising, and then the cracking can cause your discs to rupture. So you don't want any neck manipulation from a chiropractor if you have EDS. I found that if provided that it provided more pain relief than anything else without surgery. Do you know of the cervical neck specialist? You found that what provided?
I think that was the same person they were referring to.
Oh, okay, the chiropractor. I mean, I think that the chiropractor can help with a lot of things, and there are techniques that are very gentle, like strain, counter strain, and gentle massage and heat and electrical stimulation and ultrasound, and all those things can help. And so I think there's a lot of things that a chiropractor can provide. I just don't like the cracking part of it.
There are some neck stabilization exercises that were referred to earlier. I can find those and post those as well. And there are videos for those, and they're really isometric. I do them daily and they're very helpful. So I'll make sure those get added with all the rest of the content.
Great, thank you, Rahona.
What does the vagus nerve have to do with dysautonomia? So dysautonomia is the dysregulation of the parasympathetic and sympathetic nervous system, and the vagus nerve is part of that. There are vagus nerve stimulation techniques that help some people. I don't know exactly how it works or how it helps, but a lot of people use them. I don't know that it helps everybody, but it's worth a try.
I think there's one more slide of questions, Lahona. There we go.
If propanolol is not lowering heart rate in POTS, what could be the next medication to try? So midodrine slows your heart rate, mestinon slows your heart rate, Corlanor or Brabidine slows your heart rate. Some people will try digoxin to slow the heart rate. So there's a lot of medications that slow your heart rate. The trick is, what is your blood pressure doing as well as your heart rate? Because there's some medications, if your blood pressure is already low, you don't want to use a blood pressure medicine. So you just have to figure out where you're at with your blood pressure and your pulse, and then try to make a decision on which of the medications would be next to try. There's no formula, everybody's different. So if your blood pressure is really high, maybe you would need something like a alpha agonist, like a clonidine or guanfacine. So there's a lot of meds that slow your heart rate. It just depends on what else is going on, which one you're going to try. For infections with POTS and MCAS and mouths, are antibiotics okay? Also, is it okay to have immunizations with this diagnosis? So with EDS, with EDS, you don't want to use quinolones. But as far as POTS, MCAS, and mouths, so if you have mouths, you probably have EDS as well, or you're hypermobile. So we just want to stay away from the quinolones. MCAS, you'll have to figure that one out, because some people are intolerant to most antibiotics and some people can only take one or two. It's just everybody's different. I don't think there's a contraindication for antibiotics with POTS. If you have autoimmune disorders, the immunizations may not kick in, and that would be what I would worry about. So a lot of people with mast cell will end up having some sort of lowered immunity, for example, and sometimes it doesn't work. Sometimes the immunizations don't work. Sometimes people have reactions to the immunization. So I think you'd have to take that on a case-by-case basis. As far as should you have the immunizations. If you have autoimmune conditions and you're taking autoimmune medications that lower your immune system, it's the same thing. You'd have to talk to the rheumatologist. It depends on the vaccination. Is it a live vaccine or is it an attenuated vaccine? If it's a live vaccine, a lot of the live vaccines are not recommended for patients with autoimmune disorder. So it's you have to take that on a case-by-case basis. Can autoimmune diseases such as RA and heart disease make EDS, MCAS, and POTS worse? Absolutely. So everything makes POTS worse. Period. You're going out to Busch Gardens, other disorders. If your RA is acting up, your POTS is going to act up, and you have to get through the flare and then get back on the program again as much as you can. So yes, any autoimmune or other disorder of any kind can make all your other disorders worse. Can I find a primary doctor to take me as a patient? All of them turn me away the moment they see the list of meds and medication and medical conditions. Any ideas on how to navigate that and find one? I feel like a leaper. I've tried the list online in the support groups. What's a leaper?
Leper?
Leper? Oh, okay, sorry. Yeah, I think that's hard. I think, I think everybody that I see has the same problem. They've been to 15 different doctors. Each one of them has told them that they have anxiety and they're fine. And you just need to have somebody who will work with you, and you got to be patient. You know, I'll be glad to see you.
Dr. Trevino, also on the Dysautonomia Network support website, they do have a doctor's list. Also on Dysautonomia International, they have doctor's lists. So if you haven't tried there, that might be, those might be two resources that would help. This is an ongoing problem that we all face.
Kelly, if you have EPI, look into Creon. Absolutely. I struggle with these symptom issues, gaining weight while malnourished, started Creon and have been steadily losing weight and regaining energy. Yes, if you have pancreatic insufficiency, exocrine pancreatic insufficiency, definitely Creon is something that you can try. Does acupuncture help? I don't know. I treat a few acupuncturists and they tell me that it does help. My younger brother is an acupuncturist and also does Chinese medicine and herbs. I think with acupuncture and herbs, they have a lot of herbs that can treat different things based on the way they diagnose and treat things. I know with a lot of the musculoskeletal things, it can help. And I think that it can help with some of the other things too, but I don't have enough knowledge to actually comment, but from the people that I know that have had it, I would say a lot of them will tell me it does help.
Okay. Next page, Lahoma. Okay, this is a comment to you, Dr. Trevino.
Oh, you're welcome.
I found one more question here that just says, do you see patients over the phone? Does your office take Humana PPO Medicare Advantage?
We do not take any insurances at all. And yes, we do virtual visits.
But you can submit the office notes and everything to your insurance after you see Dr. Trevino, and you're just the one that's responsible for getting all the documentation to get them to pay for it, but it's not a hard process. Actually, that's a good question. Would you guys be interested in a session on how to complete insurance forms, how, you know, things like that? Would that be something that would be beneficial to all of you? Yes. Okay.
Yeah.
I see a lot of head shaking. So, all right, that's something that we've talked about doing. And so we'll make sure to put that on our list of topics.
There's just another question there too.
If there's an injury from manipulation, aggressive massage in the feet, what is the healing time? It depends on the injury, but I would say 2 to 3 times the normal amount that would be expected. It's what it's going to take.
Okay, anybody else have any other questions?
Oh, there was another thank you that I didn't put up there. I'll put it now. Oh, it said something though. Is there a comment there with it?
I'm glad you found us.
Yeah.
I'm glad you found Dr. Trevino and the group. And, you know, if there's ever any information that you want to learn about, just PM me and I'll do the research and post on that. So, well, Dr. Trevino, thank you so much for taking an hour and almost 2 hours of your time to discuss EDS with us.
Well, let me thank you guys. I mean, without you guys, I wouldn't do this because I wouldn't have not even the knowledge to do a PowerPoint the way you guys do it, and much less to use Zoom or I'm just too non-technical for that, but thanks, Morgan and you and Lahoma. Thank you all for doing this. You're the real ones who are doing it. I'm just chiming in, really. Thanks
Well,
so much for putting this together.
We set up the core for you and then you provide all the information. So our part's easy, your part is
Yeah,
answering.
not
questions.
easy for me. I wouldn't be able to do it.
Well, thank you.
Guarantee
We
that.
appreciate it. I have to give credit to Lahoma for the PowerPoint part.
Yeah, thanks so much, Lahoma.
Yeah.
Oh, my pleasure. Yes, you're very welcome. And I will try to get it as soon as possible, but I'm also a patient and I've had a very busy week leading up and I'm getting IVI maybe down for a couple of days. So just a little heads up, it may take a little while, but I'll at least be able to get the PowerPoint and stuff posted pretty quickly. So.
Great.
All right, guys. Thanks so much. And until next time.
Yeah. Enjoy your Saturday, everybody.
All right, bye.
All right.
Bye.